Good morning, all respected teachers and everyone. Today's topic of presentation is rehabilitation for head and neck cancer. So, introduction is WHO defines rehabilitation as a set of measures that assist individuals who experience or are likely to experience disability to achieve and maintain optimum functioning and in interaction with their environment. Say that at all whose systematic review of rehabilitation intervention for people with head and neck cancer shows that rehabilitation is typically considered for the physical activity and optimization of the nutritional status before treatment resulted in decreased rate of the mortality, serious complication and dysphagia, and reduced hospital length of the stay. Head and neck cancer is treated with surgery, radiotherapy, chemotherapy, immunotherapy, or the combination of these modalities. Depending on the location and the stage of the disease, treatment can have significant impact on the speech and swallowing, with the nutritional support often required. Speech and swallowing nutrition, lymphedema, trismus, and mood are area typically addressed by the elite healthcare professional, including dietitian, occupational therapist, physiotherapist, psychologist, and the speech language therapist. So, preventive rehabilitation or the rehabilitation. Rehabilitation occurs when treatment plan is developed after the diagnosis and before the commencement of acute treatment. It includes physical and psychological assessment that establish baseline functional level, identify impairment, and provide intervention that promote physical and psychological health to reduce incidence and severity of the future impairment. With effective exercise prescription, rehabilitation is useful in reducing length of the hospital stay and complications. Rehabilitation intervention vary according to diagnosis. Common modality may include cardiopulmonary rehabilitation, strengthening, stretching, and endurance exercise, aerobic exercise, nutritional management, psychological counseling, oral and swallowing exercise for head and neck malignancy, and pelvic floor exercise. Some of the goal of rehabilitations are as follow: improvement in cardiorespiratory health, improvement of the musculoskeletal function and balance, and reduce fall risk, cognitive behavior strategy to reduce anxiety and improve adaptation and sleep hygiene, optimization of the surgical outcome via modification of the risk factor, for example, smoking cessation, nutrition assessment, preoperative exercise to improve postoperative potential, for example, continence outcome after perineal surgery, and communication and swallowing function after head and neck surgery. Strategy to return to work or home with adaptive equipment and structural modification. So there are four areas of the cancer rehabilitation intervention that can address the scope and course of the illness included. That are the preventive rehabilitation, restorative rehabilitation, supportive rehabilitation, and palliative rehabilitation. So restorative rehabilitation may be offered after the surgery or when a patient is receiving chemotherapy, radiotherapy, or immunotherapy with curative intent. Rehabilitation often continue after completion of the treatment. This intervention attempt to return patient to their previous level of the physical, psychological, social, and vocational functioning. Restorative rehabilitation is usually multimodal with a combination of the early mobilization and physical therapy, nutritional management, breathing exercise with or without formal respiratory rehabilitation. Lymphedema therapy. Most surgical and some non-surgical cancer patients commence therapy as an inpatient and continue therapy in outpatient setting, supplemented by home exercise program to maintain the gain achieved earlier in the program. Second is supportive rehabilitation. As the number of the cancer survivor grow, there has been an increased focus on survivorship as distinct part of the oncological care. Supportive rehabilitation involves rehabilitation for the patient with cancer as a chronic condition. Intervention are designed to teach patient to accommodate fixed disability and minimize the debilitating changes from the ongoing disease. It increases self-care availability for the patient whose cancer has progressed and functional impairment has worsened. Other goals include preventing disuse, atrophy, contracture, loss of the muscle strength, and decubitus ulcer. Third is palliative rehabilitation. In this stage, intervention are focused on the minimizing or the eliminating complication and providing comfort and support in the terminal stage of the disease to improve quality of life physically, psychologically, and socially, while respecting the wishes of the patient and their loved ones. Such programs are designed to alleviate symptoms such as pain, dyspnea, fatigue, nausea, and edema, and prevent contracture and ulcer using medication, breathing modalities, poisoning, positioning, breathing assistance, relaxation, and use of the assistive device. Palliative rehabilitation is offered as rehabilitation physician and their multidisciplinary team. Palliative care physician and their multidisciplinary team may also provide a program of the rehabilitative palliative care, which is well established in hospice setting. So, cancer rehabilitation team consists of the oncologist, physician, rehabilitation nurse, physical therapist, occupational therapist, orthodontist, nutritionist, speech therapist, psychologist, vocational counselor, and social worker. Problem listed during the cancer treatment: pain, fatigue, lymphedema, weakness, lack of the confidence, progressive decline in the ability, muscle wasting, this disease progression, prevention of the frozen shoulder through the active and the assisted range of the motion. So first is the most of the pain can be adequately relieved by the oral analgesic. Physiotherapy can include therapeutic exercise, active or the passive mobilization technique, purposeful activity, relaxation, distraction, postural re-education, positioning and mobility, tense, heat or cold therapy, or the massage therapy. So postural muscle or endurance muscle, and common error is that people try too hard to correct their posture, leading to fatigue and poor posture habit. Good posture habit involve the staking your chest or the ribcage on your lower body and relaxed way, and then consider your shoulder girdle position and head position, both essential for the preventing or the managing neck and the shoulder pain. Fatigue. Fatigue is the most common symptoms experienced by the cancer patient. Fatigue reduces the energy, mental capacity, functional status, and psychological resilience of the cancer patient. Anemia has received the greatest attention as a source of the fatigue. Mild exercise or walking to overcome fatigue. Mild to moderate exercise to help promote energy or boost of the quality of life, when though they may feel tired. To avoid too much rest and over-exercise, which may cause fatigue by using important energy stores. Third is lymphedema. Lymphedema is buildup of the lymph fluid in the fatty tissue just under the skin. Conservative therapy of the lymphedema involves a two-stage treatment program. First phase consists of skin care, manual lymphedema treatment, and compression applied with multi-layer bandage wrapping. The bandaging achieve high tissue pressure during exercise but low pressure at rest. Simple elevation of the lymphadematous limb reduce the swelling. Patient should be instructed to avoid heat, cold, local compression, or the excessive exercise of the affected arm. The specific exercise program performed once a day is aimed at the augmenting muscular contraction, enhancing lymphatic flow and joint mobility, strengthening the limb and reduce the muscle atrophy. Phase 2 initiate immediately after phase 1 consisted of the compression by low stretch, elastic, stroking or sleeves, skincare, remedial exercise, and repeated manual lymphedema treatment as necessary. Symptoms of the lymphedema included swelling through your face, especially around your eyes, cheek, neck, or the chin, stiffness in your neck or the jaw, difficulty with swallowing, speech, or the breathing. So, this is the exercise for the lymphedema. Trismus or the temporomandibular joint dysfunction. About 50% of the patient had limited mouth opening, less than 36 millimeter, and patient with oral cancer significant higher risk of the trismus. Physical therapy can help relax the muscle, increase joint flexibility, and other oromotor exercise. Diet should be fairly soft and chill. Moist heat is very helpful to relax the muscle. Jaw and neck exercise, which will help the muscle stretch, passive joint mobilization, re-education of the jaw movement, scar mobilization, and strengthening exercise to jaw muscle play a vital part after the surgery or the chemoradiotherapy. Different devices are available for the jaw stretcher, such as Therabite TMJ exerciser. Therabite is an effective physical therapy intervention to manage the trismus. So, exercise for the TMJ pain. This include the next is shoulder dysfunction. Shoulder dysfunction caused by spinal accessory neuroplasia, neurectomy in the head and neck cancer survivor. The goal of the exercise program was to enhance scapular stability and strength of the upper extremity. The therapeutic exercise consists of the supervised active and the passive range of motion, stretching exercise, postural exercise, and basic strengthening exercise with the lightweight and elastic resistance band. If the nerve is damaged or sacrificed during the surgery, your shoulder will sit lower on that side, droop shoulder, and shoulder blade may wing out backward. Both these issues will lead to difficulty in using your arm above shoulder height due to weakness of the supporting muscle and cause pain and stiffness in the shoulder. If the nerve has been sacrificed, the muscle will not recover their function as the muscle supplied by the nerve will not able to activate it, will not work. Neck surgery can sometimes just fuse or injure the nerve without permanent damage. It will affect the muscles of the shoulder and neck in the same way. Unfortunately, this can take many months for the recovery, so we need to ensure that shoulder and neck move will in this time to stop stiffness developing. So these are the exercise for the neck and shoulder. First, we have to press our forehead to the backward direction for the 5 seconds. Then turn the neck for the opposite, both side of toward the shoulder, and press with the another hand to mobilize the neck. All exercise we have to done 10 times for the first time, and then continue for the 10 times in a day. These are the isometric exercise for the like place the hand behind the head and keep it for the 5 seconds. Then compress the forehead for the backward for the 5 seconds. Then press the forehead for the opposite side and we exercise certainly the foundation really bargaining. Ma'am, actually, in rehabilitation, we have to guide the patient कि इसके बाद ऐसा ऐसा कर सकते हो और exercise हम पहले से भी start कर सकते हैं. There's a multiple study I have added in this. मतलब ये जो गाना चल रहा है शोल्डर स्टिफनेस ये सर्जरी के पहले ये सर्जरी के बाद है बटन पेशेंट को लिम्फेडिमा भी नाम सर्जरी के बाद और क्रिसमस क्रिसमस भी सर्जरी के बाद बट मैम क्रिसमस कभी कभी पेशेंट को पहले भी हो सकता है बिकॉज ऑफ डिसीज और हम सारी एक्सरसाइज पेशेंट को पहले भी स्टार्ट करवा सकते हैं आफ्टर डायग्नोसिस एंड बिफोर ट्रीटमेंट कमिशन तो उसमें बेनिफिट्स नहीं हम लिम्फेडिमा नहीं बट बाकी के एक्सरसाइज पेशेंट को बता सकते हैं कि बाद में आपको ऐसे ऐसे कॉम्प्लिकेशंस हो सकते हैं तो आपको ये भी करना तो पेशेंट गाइड हो जाता है उसके अकॉर्डिंग Dysphagia, the main reason of swelling problem are thoughtful to reduce through the tongue strength, reduce laryngeal elevation, reduce tongue base retraction during the swallowing, and fibrosis of the muscle involved in the swallowing. Diet modification and motivation, maintaining tongue strength and mobility, laryngeal muscle exercise. Placing a piece of the eyes at the back of tongue and do the exercise. Mandelson maneuver, holding the larynx in its most supine position using swallowing for 2 to 3 seconds during each swallow. So these are the swallowing exercise for the patient. This is the tongue exercise for the tongue strength after the resectability. First, we have to place the tongue over the palate, then the both cheek. These are the lip exercise. This is the jaw mobility exercise. This is the for the cheek fibrosis exercise. We have to full air full in our mouth and these are the swallowing exercise. First is the mask maneuver, second is the Mandelson maneuver, and third is the supraglottic maneuver. In Moscow maneuver, we have to hold the tongue between the teeth, then swallow while tongue held in this position, and repeat this for the 10 times in a day. Second is the Mandelson maneuver, which initiate the swallow as soon as larynx elevate to the highest position. Squeeze the throat tightly together. Hold the tight throat squeeze for the 3 to 5 seconds, then relax and complete the swallow. This is the supraglottic exercise. Breath and hold your breath, then swallow while holding your breath, and then cough. Third is chemotherapy-induced neuropathy. Chemotherapeutic agents may develop the peripheral neuropathy that can result in sensory, motor, and automatic deficit. While some patient deficit will resolve quickly after the cessation of the chemotherapy, others have persistent peripheral polyneuropathy that may impact strength, balance, and function. Exercise can restore function in extremity, also enhance balance, strength, and safety. And braces can be used to support weak muscles. Cervical contracture, exaggerated thoracic kyphosis associated with the radiation-induced soft tissue contracture in head and neck cancer patient. Active range of the motion exercise in all plane of the neck motion should be initiated as soon as safely possible. Postural correction and the strengthening of the cervical extension exercise. Manual fibrous release technique are indicated when range of motion is restricted by the soft tissue fibrosis. Respiratory complication and DVT prevention. Oral cancer ablative surgery mostly involve the excision of the muscle and the mucosa required for the swallowing. The resultant handicap reduce risk of the aspiration and respiratory complication. Since most of these patients are smokers with compromised respiratory function, it is important to initiate chest physiotherapy and ambulation early in the postoperative period. This exercise for the cheek fibrosis after the surgery. तो ये जिस साइड से सर्जरी हुई है उस साइड से कंप्रेस करके देन वी हैव टू pull our mouth with the balloon and compress towards the other side. This exercise for the difficulty in swallowing, we have to take a long breath and hold it for the 5 seconds. Then we have to inhale or exhale for the mouth. Mhm. 15 weeks rehabilitation program for the cancer survivor and found significant improvement on the health related quality of life, mood, and physical performance during and after the treatment. Muscle strengthening exercise may be either isometric, isotonic, or isokinetic. Task oriented exercise such as ambulation or the training in self care may improve function and safety by repetition and prolonged therapy. So next is the nutritional management. Nutritional support and intervention is an integral component of the head and neck cancer management. Patient can be malnourished at present, and the majority of the patients undergoing treatment for head and neck cancer will need nutritional support. A specialist dietitian should be part of the multidisciplinary team for the treating head and neck cancer patient throughout the continuum of the care, as frequent dietary contact as has been shown to have enhanced outcome. Offer pre-treatment assessment prior to any treatment as intervention aimed to improve, maintain, or reduce decline in nutritional status of the head and neck cancer patient who have malnutrition or are at the risk of the malnutrition. Regardless of presenting body mass index, unintentional weight loss of the 10% or the greater in preceding 6 months may lead to range of the problem. Early nutritional intervention is essential to correct pre-existing nutritional deficiency with regular review throughout the patient's journey in order to optimize nutritional status and correct nutritional related problem at each state of the treatment. So malnutrition associated morbidity are increased risk of the infection, delayed wound healing, impaired function of the cardiac and the respiratory system, muscle weakness, depression, poor quality of the life, increased risk of the post-operative complications, reduced response to the chemotherapy or radiotherapy, increased mortality rate. So, nutritional assessment parameters are clinical observation include ability to chew and swallow, clinical sign of the weight loss, ill-fitting denture or the clothing, medical history which may affect nutritional intake, celiac disease and diabetes. Dietary history included review of the recent intake 24-hour recall within attention being patient to fluid intake, change in the texture, report of the fullness, length of the time and effect taken to the eat, change in appetite and GI function. Calculation of the requirement energy 20 to 25 to 35 kilocalorie per kg per day, dependent on the activity level, can increase further in major complication. Protein 0.8 to 2 gram per kg per day for depleted of the treatment complication. Fluid 30 to 35 ml per kg per day, increase in infection and excessive fluid loss. Vitamins and minerals included as per recommended daily amount unless considered deficient. Next is proposed treatment, disease status, tumor site, nutrition implication, or the previous and the current treatment plan. Anthropometry include height, weight history, percentage weight change, body mass index less than 18.5 kg per meter square, suggest undernutrition. Triceps skin fold thickness indicator indicates for the fat store. Mild arm muscle circumference indicate lean tissue mass. Hand grip strength assess muscle function. Next is biochemistry. Urea and electrolyte include the fluid status, also can be discussed by the disease state and treatment. Albumin not the good indicator for the nutrition status due to its long half-life and its affected by the stress and sepsis. The albumin's shorter half-life, 2 to 3 days, but also affect the infection and the stress. C-reactive protein, transferrin, and total lymphocyte count all affect the infection and the inflammation. Refeeding syndrome risk. Social information included alcohol intake, smoking, substance misuse, social support, dentition, access to food and cooking skills, social and financial circumstances, time taken to eat and drink, patient perception of the nutritional status. So, criteria for initiating preoperative nutritional support. If weight loss is more than 10 to 15% in 6 months, body mass index less than 18.5 kg per meter square, subjective global assessment grade C, serum albumin less than 30 gram per liter, and unable to maintain intake above 60% of the recommended intake for more than 10 days. Estimating nutritional requirement for the patient. Aim of the energy of at least 30 to 35 kilocalorie per kg per day. As energy required may be elevated post-operatively, monitor weight and adjust intake as required. Aim for the protein intake at least 1.2 gram protein per kg per day in a patient receiving radiotherapy or chemotherapy. Start nutritional therapy if undernutrition already exists or if it is anticipated that patient will unable to eat for more than 7 days. Enteral nutrition should also be started if inadequate food intake, 60% of the estimated energy expenditure is anticipated for more than 10 days. Nutritional consideration during surgical treatment, preoperative nutrition. Inadequate oral intake for more than 14 days is associated with a higher mortality. Patient with severe nutritional risk should receive nutrition support for 10 to 14 days prior to the major surgery, even if surgery has to be delayed. Consider carbohydrate loading in the patient undergoing head and neck surgery. Enteral nutrition is indicated even in patient without obvious undernutrition if it is anticipated that patient will be unable to eat more than 7 days perioperatively. Post-operative nutrition. Early post-operative tube feeding within 24 hours is indicated in patient in whom early oral nutrition cannot be initiated. Early oral feeding after primary total laryngectomy is thought to reduce length of the stay. There has been shown to be no difference in fistula rate compared with the delayed oral feeding of more than 7 days. Nutritional management for the Kylie. This is rare complication with the incidence of the 1 to 2% following radical night dissection and less common with the selective night dissection. The management may be conservative, including dietary manipulation or the further surgery. A post-operative leak gives a fluid or a milky appearance. Triglyceride level more than 110 mg per dl is diagnostic for the Kylie. The principal aim of the nutritional management to reduce the flow of the chyle while maintaining nutritional status, ensuring adequate fluid balance and replacing electrolyte. Nutritional management is used of fatty and high to medium chain triglyceride product. Medium chain triglyceride is recommended because it is directly absorbed into the portal system, resulting in less chyle production. If dietary manipulation is unsuccessful, parenteral nutrition may be required. This should not be used as first line management except in the extreme cases. In case of very high volume leak. Nutritional consideration during radiotherapy or the chemotherapy. Intensive dietary counseling and oral nutrition support to increase dietary intake and to prevent treatment associated with weight loss is recommended for the patient and undergoing radiotherapy of the head and neck. Tube feeding is recommended if the cancer interferes with the swallowing or if mucositis is anticipated, which may be interfere with oral or the pharyngeal swallowing. Weekly or twice in a week, dietetic intervention is offered for the all patients undergoing radiotherapy treatment to prevent weight loss, increase intake, and reduce treatment interruption. Z-feeding syndrome. Z-feeding syndrome is consisting of metabolic disturbance that occur as a result of the reintroducing of the nutrition to the patient who are starved, malnourished. It can occur irrespective of the feeding route. The main feature is hypophosphatemia, but can feature abnormal sodium fluid balance, change in the glucose, protein, and fat metabolism, thiamine deficiency, and hypokalemia and hypomagnesemia. By defining the feeding syndrome as a reduction in the serum phosphate to below zero point 0.4 millimole per liter. Criteria for determining at moderate or high risk developing Z-feeding syndrome. Patient has one or the more following. Patient has one or more of the following, which include body mass index less than 60 gram per meter square, unintentional weight loss greater than 15% within the last 3 to 6 months, little or no nutritional intake for more than 10 days, low level of the potassium, phosphate, and magnesium prior to the feeding. Or it includes patient who has two or more following, including body mass index less than 18.5 kg per meter square, unintentional weight loss greater than 10% within the last 3 to 6 months, little or no nutrition intake for more than 5 days, history of the alcohol abuse or the drug including insulin, chemotherapy, antacid or diuretic. So management for the refeeding syndrome included patient at risk check for the potassium, calcium and phosphate magnesium. Before feeding start, administer thiamine 200 to 300 milligram daily orally. Between B, high potency 1 to 2 tablet 3 times a daily. And multivitamin for or the trace element supplement once in a day. Start feeding slowly increase feeding over 4 to 7 days. Rehydrate carefully and supplement and the correct level of the potassium, phosphate, and magnesium. Monitor potassium, phosphate, calcium, and magnesium for first 2 weeks and treatment as appropriate. Next is cancer cachexia. Cancer cachexia syndrome include result in the decreased appetite, weight loss, metabolic alteration, and inflammatory state that cannot be fully reversed by the conventional nutritional support and lead to progressive functional impairment. Pro-inflammatory process can lead to insulin resistance, increased loss of the body fat mass, and production of the acute phase protein. Cytokine-induced metabolic alteration can prevent cachexic patient from regaining body cell mass during nutritional support and not relieved by the conventional nutritional intervention. For the normal pre-cachexic include weight loss less than 5%, anorexia and metabolic changes. In cachexia stage, weight loss more than 5% and body mass index less than 20 and weight loss more than 2%. Often reduce the food intake and systemic inflammation. Refractory cachexia include variable degree of the cachexia, cancer disease, both pro-catabolic and not responding to the anti-cancer treatment. Um, the management approach should be multifactorial and include assessment and ongoing monitoring with intensive nutritional support, anti-inflammatory treatment, symptoms control as well as oncological treatment option to reduce catabolic effect of the cancer. So endpoint is offer prophylactic tube feeding as a part of the locally agreed guideline where oral nutrition is inadequate. Offer nutritional intervention, dietary counseling, and supplement for up to 3 months after the treatment. Patients who have completed their rehabilitation and disease free should be offered healthy eating advice as a part of the health and well-being clinic. Quality of the life parameter, including nutrition and solving, should be measured at diagnosis and at regular interval post-treatment. Psychological support included diagnosis and treatment of the head and neck cancer are emotionally and physically stressful period for the patient with high risk of the depression and suicide. So objective of this psychological work are to reduce preoperative and pre-treatment anxiety, to promote patients' awareness and to inform, motivate, reassure patients about possible rehabilitation and prosthetic intervention regarding solving and phonation. In recent year, our new psychological approach with cognitive behavior intervention has been implemented in clinics with the goal of the improving functional impairment and post-treatment psychological stress. Cognitive behavior intervention is process by which patients learn to become expert of their own behavior, learning to examine their own thoughts, recognize when negative thoughts are increasing, and then apply a number of the strategy to alter those negative thoughts and emotions. In addition, CBI other initiatives such as psychoeducation, meditation, mindfulness, group therapy, telehealth initiative have been implemented in last 30 years. Longer time spent meditating daily was associated with a higher post-intervention mindfulness. So, some active clinical trial in head and neck investigation, rehabilitation intervention. In this first trial included NCT 05418842. That is the trial which include randomization and treatment included chemotherapy and radiotherapy. In this, they evaluate the effect of the rehabilitation based on the exercise training on the functioning capacity, included 46 patients uh, in two groups, rehabilitation group and the usual care group. So, rehabilitation intervention included exercise training. Primary outcome was the functional capacity and major description of the primary outcome is 6-minute walking test. Next trial included NCT 05745558. Randomization not include. They include the surgery and the intervention is multimodal training and nutritional smoking cessation, psychological counseling. Primary outcome was feasibility and major description was self-designed questionnaire score, number of the session and patient participation and patient willing to participate. In this, they include 60 patients for the 3 to 6 week for the prehab rehabilitation program. And there is two on feasibility and the effectiveness. In feasibility, they include the percentage of the patient willing for the participant in the rehabilitation program. And effectiveness is the complication, health status, or the compliance to the health lifestyle. Third is the NCCT of 045908087. Treatment included surgery and the rehabilitation included anaerobic and resistance training, in which they included the 6-minute walking test. Outcome was the quality of the life and measure the functional assessment of the cancer therapy, head and neck cancer. Last one is the NCCT 06079697. They included the treatment surgery and the same is the rehabilitation is included exercise training. Outcome was the post-operative mobility, daily step count on the Fitbit or the personal wearable device. These are the study which included in the meta-analysis. So, in the first study, Vander Malone et al. Study design was randomized control trial. Type of the intervention is rehabilitation exercise. Sample size included experimental 24 patient and standard 25. Uh, age mean age was 56 year or the 55 year in the both group. Follow-up was for the 3 months. Inclusion criteria was patient with the advanced oral cavity, oropharynx, hypopharynx, larynx, or the nasopharynx. Cancer treated with the CCRT. Primary outcome was swallowing function. Conclusion: this study shows the pre-treatment rehabilitation is feasible and then acceptable compliance can be obtained despite the burdensome effect of the concurrent CTRT. Early post-operative functional outcome for the patient with advanced head and neck cancers seem to include the either of two exercise regimen used in this study. Long-term effect to be awaited before definitive conclusion can be drawn. Next is the Kulversh et al. That is the cross-sectional study, pre-treatment and pre-operative solving exercise was the intervention. Sample size including experimental or the control group 25 and 12. Comparative group post-treatment exercise, first visit after the initiation of the treatment. So follow-up for the 20 months inclusion criteria was patient with head and neck cancer undergoing radiation or chemotherapy. Primary outcome was primary outcome assessment. Conclusion was patient who performed pre-treatment following exercise before head and neck cancer therapy, and this study had significantly increased in swallowing quality of life when compared to the patient who performed only post-treatment swallowing exercise. Next is Ho et al. That include the prospective cohort study. Type of the intervention is impact of the early nutritional counseling. Sample size was early nutritional counseling, 105, late counseling, 102 patient. Comparative with the normal nutrition, follow for the 1 to 2 years. Inclusion criteria was patient age more than 20 years, patient diagnosed with locally advanced head and neck cancer, patient who received CCRT. Primary outcome was survival rate. Conclusion was our finding strongly suggests that while some head and neck patients who have pre-treatment normal nutritional status and early nutritional counseling is nevertheless essential for the improvement of the treatment tolerance and survival outcome. Last one is Lin et al. Study design for the randomized control trial. Type of the intervention is exercise for the head and neck. Sample size including 20 patients in each group. Control group received no specific information regarding the exercise. In follow-up for the 8 weeks, inclusion criteria including adult more than 20 years, diagnostic for the head on diagnosis for the head and neck cancer, schedule for to receive chemotherapy, no brain tumor, no serious complication, no history of the mental illness. Primary outcome was the body composition, muscle strength, balance, flexibility, cardiovascular fitness, health-related quality of the life. They include the combined aerobics, resistance, and flexibility exercise program during chemotherapy may improve physical fitness, muscle strength, balance, flexibility, body composition, quality of the life, alleviated and deterioration of the cardiovascular fitness in the patient. Next is the Muller et al. That include the preoperative immunonutrition, comparative group with the usual care, follow-up for the 1 year, inclusion criteria head and neck cancer patient undergoing radiotherapy. Primary outcome was overall wound complication within the first 30 days after the surgery. Patient undergoing salvage surgery for the recurrent head and neck SCC preoperative immunonutrition exhibit favorable effect on the complication rate and consequently reduce the length of the hospital stay. What do you mean by immunonutrition? Ma'am, we can include the albumin and the transference for the immunonutrition treatment. Transference is it? Malik et al.'s prospective study included the psychoeducation intervention, in which they include follow for the 2 years head and neck cancer patient undergoing radiotherapy. Primary outcome was overall survival, regional T survival, and late toxicity. We have at our institution is associated with improved long-term oncological outcome. Prospective data needed to be better understood. So conclusion is integration of the multimodal rehabilitation program, including nutrition intervention, physical activity, psycho-oncologic support is a crucial in the care of patients with head and neck cancer. Despite of the promising benefit of demonstrated by various studies, the implementation of the rehabilitation in clinical practice remain limited due to several barriers, including standardization, variability in patient engagement, inadequate resources within the healthcare system. By fostering a multidisciplinary approach and promoting early intervention, we can better prepare patients for the challenge of the cancer treatment, ultimately improving survival rate and quality of the life.